Hello, everybody. Thank you for joining us today for MVC's post-discharge follow-up work group presentation. My name is Rachel. I'm one of the site engagement coordinators with MVC. It's my pleasure to be facilitating the work group for you today. Here's our agenda for this work group. We're going to go through some of our regular housekeeping and P4P credit reminders. We will have a presentation by Sara Hagerman from University of Michigan Sparrow, University of Michigan Health Sparrow. And then following that, we will have a discussion time, and then we'll go over some of our MVC updates and upcoming events. Few housekeeping items to remember. We are recording this work group. The slides and the recording will be shared with attendees following the work group in our email that we send out. Just a reminder that that email sometimes comes out later in the afternoon due to video processing and all the other things that go into the information we put in there. Please remember to mute your microphone unless you are asking a question or talking during the discussion portion. This helps reduce any background noise. And then you can also be putting questions into the chat throughout the presentation. We will go through those at the end at the discussion portion. For our P4P participating sites, with just a reminder that we do want you to have active participation for the work group. That means answering any polls or, being a part of the discussion and asking questions or, giving, your point of view from your site. And then also at the end of the work group, we'll be posting the post-work group survey link. This survey is a requirement to be completed for our P4P sites to receive engagement points for the work group. But just so our non-P4P folks know, you can also fill out the survey and just provide us with some valuable feedback on the work group, letting us know what you think and if there's anything else that you'd like to learn about at future work groups. All right, today's presenter is Sara Hagerman. She is the Quality Performance Improvement Specialist with University of Michigan Health Sparrow at the Clinton, Carson, and Lansing sites. Sara is a dedicated healthcare leader with over 20 years of nursing experience. She's currently serving as the Quality and Performance Improvement Specialist. In this role, Sara supports quality initiatives and drives performance improvement projects across two of an organization's community hospital sites, ensuring delivery of safe, effective, and patient-centered care. With a strong clinical foundation as a registered nurse, Sara brings extensive leadership experience from a variety of critical care settings. Prior to her current position, Sara held roles including emergency department manager, trauma program manager, and manager of outpatient oncology. Passionate about continuous improvement, patient safety, and team development, Sara is committed to fostering a culture of excellence in every aspect of care delivery. Great. And then with that, I'm going to be passing off the baton to Sara for her presentation.
Wonderful. Thank you so much for having me. We just wanted to take an opportunity to share a little bit of the work that's been happening at our Carson location. So if you want to flip to our next slide, we'll get going here. I just wanted to take a minute just to point out our mission and values. It's important for us that we use our caring, innovation, inclusion, integrity, and teamwork to advance our mission, which is to advance health, to serve Michigan and the world. So if you want to flip to the next slide, I just wanted to show everybody where our hospital is located in Michigan, kind of right in the middle of the mitten, so to speak. We are one of 4 community hospitals in the Sparrow system. So if you'll flip to the next slide, please. Just a little background about the hospital in Carson City. We were an independent hospital up until 1997 when an affiliation with Sparrow started. And then in 2015 became fully integrated with the Sparrow system. And then 2024, Sparrow integration with University of Michigan Health. So now we are currently the University of Michigan Health Sparrow Carson. So just a little bit about our background. If you would like to flip to the next slide. And I just wanted to share a little bit about who we are, because sometimes small rural hospitals, people don't quite understand where we're located, what services we provide. So there's a picture here in the corner. That's the front of our hospital, looking at our front lobby. We are a level 4 trauma designated hospital. We are a Blue Cross Blue Shield patient center medical home. We have 5 primary care practices, 8 specialty practices, and we do provide full inpatient medical care, and we have a full surgical services department as well. I want to flip to the next slide. Just some of the additional services that we provide. We have several specialty clinics. We have wound, infusion, women's health. We have very robust pain clinic and outpatient PT/OT, among all the other typical services that you would find, in the inpatient or in the hospital realm itself. Next slide, please. So our focus today, our project that we've been working on is specific really to our medical surgical inpatient unit. And I just wanted everybody to have a little bit of background on the capability or functionality of our med-surg unit. We average between 7 and 9 patients per day. We are adding swing bed capability this summer. We actually had just our first swing bed patient a week ago here at Carson, so we're excited to add that new service line. Our typical staffing, just basic staffing, 2 RNs, a patient care tech, supervisor that kind of helps assist the whole house. And then on Monday through Friday, we typically have a unit clerk and a discharge planner. Our patients on the inpatient floor typically stay for about an average of 3 days. So really, like I said, our goal, we want to improve HCAHPS and decrease readmissions. And so we targeted kind of this project in 3 different areas, starting with a focus on social determinants of health. And then we looked at how are we individualizing a care plan for all of our hospitalized patients or patients that are going to discharge, and then what our process looks like in the outpatient realm. Once patients are discharged and they're following up with their primary care, specifically the role of our care facilitator in the outpatient setting. So 3 primary kind of focus areas that we hoped would reduce readmissions and improve our patient satisfaction. Just a picture of what that tier 2 strategy huddle board looks like. It's actually a physical board that hangs on the wall just outside of our administration hallway. We meet at this board as leaders every other Tuesday morning and discuss all of our quality metrics, metrics related to access, belonging, inclusion, all sorts of things. But our social determinants of health, screening compliance was one of our strategy metrics that we discussed, every other week for the last fiscal year. Want to flip to our next slide. So once we were able to gather data for about a year in the EHR, then we had to do something with the information that we've collected. So kind of our next steps were to really aggregate this data, drill down and kind of look at it more closely. So the data on the right-hand side of your screen is our fiscal year scores. So for the year, we had 465 inpatients and we screened 92% of them. With that information, we noted that food insecurities, transportation needs, and housing instability were our top 3 social determinants that were coming up the most often. So then our executive leaders really went to work on what does that look like in our community and how can we make improvements based on this information that we've gathered, kind of on a macro level instead of a micro level. So we were able to work with one of the transportation services in a neighboring county to get them, an agreement for them to come provide some services in Montcalm County that we hadn't had before. And then our executives also were working on, how do we tackle housing instability from a hospital standpoint, started having conversations like in the community about what does that look like. So really we wanted to use this data and this information, like I said, on the larger scale level. And then also we wanted to use it for, each individual patient, that screening that's completed, one patient that screens positive for food insecurity, how's our discharge planner going to work that individual screening into the patient's discharge plan. So we're really trying to focus on more resources available in the community, and then also how do we tailor an individual care plan to provide the resources that are necessary. I just want to flip to the next slide. I think that leads us right into like individualizing our discharge plan. So in addition to screening for social determinants of health and making sure that patients have support and services based on those screenings, we also want to make sure that our patients are following up with their primary care. And so over 90% of our patients that discharge home from the hospital have a scheduled follow-up appointment before they leave the hospital. That's something that we worked very hard on. We have a really great relationship with our local primary care, and they often leave slots open on their schedule so that we can get discharged patients on their schedules very quickly. They also are very helpful in getting patients scheduled that don't have an established primary care. I know that in the past that has been a really big problem for us getting those patients scheduled, and that has gotten significantly better as our collaboration and relationship with our primary care has just continued to get better and better. So our discharge planners really focus on making sure that those patients have appointments before they discharge, making sure that whatever they screen positive for in their social determinants of health screening, making sure that they have resources available, and then making sure that patients, once they discharge from the hospital, that they really know who to call or who to reach out to if they have a problem or a concern. Our patients are able to call right back to our inpatient unit and speak with either a nurse or our discharge planner for a full 3 days after they discharge. After that 3-day mark, we often refer them to primary care so long as they're established with primary care. But we really try to be like a conduit between primary care and the patient if it's needed and necessary. The other thing that our discharge planners do is they call patients back after discharge. So they typically are able to reach at least 90% of our patients that are discharged home. Their goal is to contact them and reach out to them within 72 hours of discharge. And we've been very successful with that initiative as well. If you want to flip to the next slide, please. Okay, so that was a little information about, our discharge planner and their outreach. And then once the patient discharges to home, we kind of turn some of that care over to our care facilitators. So we have RNs who are embedded right in our primary care offices. And a lot of their job and responsibility is to identify patients within the practice that are chronically ill and help to support those chronically ill patients. Part of their role is to contact patients who have discharged home from the hospital. And once they get a hold of those patients, one of the important things that they do is a medication review. So they're going to go through all of the patient's med rec on the phone with the patient, hopefully within 48 hours of discharge. But they really focus on a couple specific areas. They focus on any changes in medications that were made or any additions to medications. They obviously are validating to make sure that patients picked up their prescriptions, received any equipment that they needed. They provide lots of education to patients and families about discharge instructions, Again, they are also a conduit between their primary care provider and, the hospitalist who created discharge instructions. So and then the other thing that they can do is potentially enroll these patients in what we call chronic care management program. And if you want to flip to the next slide, we're going to talk just a little bit about what chronic care management in our outpatient setting looks like. Any patients that have 2 or more chronic conditions that are anticipated to last for a full calendar year are eligible to enroll in what we call chronic care management. When a patient is enrolled in that program, they have like monthly touch bases or like monthly appointments with that care facilitator or with that embedded RN to talk about things like education. They will develop specific goals and care plans related to the patient's chronic conditions. Those CHF patients, they might have them on a plan to get a daily weight and report their weight back to the office if they have a certain amount of weight gain within a established time frame. So they're really working with patients to get patients more engaged in their own care, to track and manage those really chronically ill patients, and to have like individualized plans for health improvement. And they typically spend a minimum of 20 minutes per month with each of these patients enrolled in this program. So one of the interesting things about CCM or chronic care management services is they are reimbursable by Medicare. And so some of these care facilitator roles are revenue generating roles. If you want to flip to our next slide. I just kind of wanted to throw out there some of the positive things that we've seen as a result of chronic care management program and the work that our care facilitators are doing out in the outpatient setting. So we've definitely seen some improved patient outcomes, and I would say especially our diabetic patients who are needing lots of education about diet and medicine. Seen some very positive outcomes there. We've seen, some revenue generation, a reduction in hospitalizations. We definitely have seen increased patient engagement and improved care coordination because of that role in those programs. Next slide, please. And so I just also wanted to share some maybe gaps that we noticed as we went through some of our improvement process, and maybe some lessons learned. So one of the gaps is, we're a small hospital that has a discharge planner, established discharge planner just Monday through Friday. So we don't have that social worker aspect available on Saturdays and Sundays. We do have nurses who are working on a discharge plan and individualizing a discharge plan, but we don't have that social worker available on the weekend. The other gap that we have seen is our chronic care management program does come with a deductible for patients. Medicare typically requires patients to cover an annual deductible, and then they're responsible for 20% copays after that. And chronic care management falls under those same regulations. So there sometimes is a barrier to patients wanting to enroll in that service and have those appointments or meetings with that care facilitator, with that nurse, because there are times where a patient is responsible for a deductible. Some patients that have like co-insurance and secondary insurances, the cost is completely covered. So it's just patient dependent. But we have seen that has been a barrier at times. I would also say that chronic care management billing is pretty complex. There are specific codes and documentation requirements that make it a bit complicated. But overall, the program is just pretty incredible. And I would say some lessons learned on our HCAP side, as we were really trying to improve our HCAPs, is ensuring that your whole team is aware of the content of your HCAP survey and what questions are the patients going to be asked. I think we made some assumptions that, you know, everybody in the healthcare world understands and knows what HCAPs are, but we definitely learned that not all of our staff knew what the patient would be asked in that post-discharge survey. So even just making sure that the team knows, oh yeah, there is a question on the survey specific to discharge, or there's a question specific to how quiet are things. That was something that was kind of like, oh, I think we made an assumption that our staff really understood what that survey looked like. I would encourage anybody looking at any of these initiatives or projects to make sure you're assembling a multidisciplinary team. That's something I think we actually did pretty well on. We established readmissions reduction subcommittee, so to speak, and we were able to include staff from the outpatient settings, like either a care facilitator from our local site or a care facilitator who works with those chronic care management issues from our hub in Lansing. So having them as part of our team was pretty important. And then I would just say sharing data and outcomes is something I think we could do a little bit better. We have done some sharing of our process, our projects, and our improvement in data, but I would say we probably have more opportunity to share the good work that's happening across the organization and with our physicians specifically, so that they are seeing metrics and data. And I think that might be my last slide. I'm sure we'll have time for questions.
All right, thanks, Sarah. Anybody? Let's see, it looks like maybe we have a question in the chat here from Benji. If a patient goes home with home care, are they still eligible for the chronic care management program, or is that expected to be part of the home care?
I would have to probably get back with somebody on that. I think our care facilitators that enroll patients in chronic care management would probably be better able to answer that question. My initial thought is I don't think that they can be enrolled in both programs at the same time, but I would want to validate that and get back with the group.
Okay, it looks like Alex has a question. Go ahead, Alex.
Couple, but I can do one at a time. Great presentation. Thanks so much. I wondered if you guys ever have access issues as far as getting patients into a primary care provider, and if so, any strategies that you found to be successful there.
I think, yeah, we've definitely have struggled with that in the past, but I think we're doing much better currently than we have in the past. I think having a connection and a relationship with your primary care office and making sure that they understand the priority nature of getting these patients scheduled. Our offices have been so wonderful that, like I said, they are leaving, you know, some space in their schedule on a routine basis to put, you know, either emergent cases, urgent cases, follow-up cases for us. And I would also say the staff that we have scheduling our appointments, so the staff in the hospital that are working on creating those appointments or scheduling that, it's real priority work for them. And so they have built some connections and relationships with the staff in the primary care setting. So I think that because it's a priority for staff at both locations, we've been able to make an improvement. Our unit clerk is typically who works on scheduling those appointments for patients before they leave. And because she's typically here Monday through Friday, she even on Friday will look and, you know, anticipate who may be discharging on Saturday and Sunday and work to make sure that those patients have appointments before end of day Friday. So it's really just a priority, I would say, for everybody.
Thank you.
Okay. I guess I can ask the audience, has anyone at their sites utilized the patient experience satisfaction survey for improving the post-discharge care. And then if you've seen any positive outcomes at your site as well. All right. Charles says we have not, but this is something that they're going to take forward. That's awesome. Great. Go ahead, Alex.
Yeah, I wondered if you'd be willing to share kind of that script that you're using right now for those post-discharge follow-up, and then if is it a hospital-based nurse that's calling or a care manager for the outpatient setting, or does it depend on the specific patient situation?
So we have two people who are calling patients typically. Our discharge planner from the hospital is calling patients within 72 hours. And then also the care facilitator in the outpatient setting is calling patients for follow-up. And their goal is to touch base with patients within 48 hours of discharge and going through a whole array of follow-up specifics for those patients that are discharged.
Got it. So I work with Munson Healthcare, and we just switched our inpatient hospitalist group. So we have a contracted group that covers now our 7 hospitals, and they are looking to implement a survey. They already have a script, but I'm just kind of curious on the differences. That's actually administered by that service, by that hospital group serviced. And it's got some questions about medication and transportation and stuff. So curious to see the similarities. Thank you.
Yeah, I think we could share that.
Awesome. Looks like Heather put in a comment that they have implemented a similar satisfaction survey. They developed scripting for staff, and they saw a 38% increase in the Net Promoter Score and HCAHPS scores directly correlating to a decrease in readmissions. That's awesome. Thanks for sharing, Heather. All right. Let's see here. Sara, do you have any recommendations for sites that are considering doing a similar project?
I would just, my two big recommendations would probably make sure you have a multidisciplinary team, engage with your outpatient, primary care providers and locations. And if you can get one of their team members to be on your committee or team, I think that is huge. And then whatever patient satisfaction survey you're using, make sure your staff know about it, make sure they know the content, and make sure you're sharing routine feedback with performance with your team.
All right. Awesome. Thank you, Sara. All right. It seems like our questions in the chat are slowing down, so we are going to go ahead and move on to our MVC updates and events, unless there's any last minute ones coming in. Okay. All right, here we go. Moving on over. So upcoming work groups for MVC. Our next work group is going to be on Tuesday, August 12th. It will be a preoperative testing work group with a presentation from Holland Hospital on their MSQC pre-op testing project that they did. And then following that will be our Health in Action work group on August 28th. And that'll feature a presentation by MD HHS on the innovative behavioral health model and the home care program that they are working on with that. And then if you've missed our previous work groups in June, you can see the recordings for those on our YouTube channel. And then we also highlight the work groups on the MVC blog, which is on our website and gets sent through the emails with our newsletter. Upcoming events. Sites can look forward to getting their common conditions reports in Q3. We don't yet have a final date for when we're sending that out, but they are working on it. And then we do have an August virtual networking event coming up on August 25th, 24th, 21st. And that's going to be 12 to 1:30 p.m. via Zoom. And it's going to have a rural health critical access hospital focus. And we're going to kind of talk about how claims data can be used at these usually smaller sites and how MVC can help with that. Registration is open for that, and so the link will be provided in the email that comes out after the work group. And then finally, we are still looking for presenters for the remainder of 2025. We do have a few work groups that we're looking for presenters, and then we are also looking for presentation proposals for our fall collaborative wide meeting, which is October 10th. And that information is all on our website. If you are interested in doing a presentation, the link for that is going to be in the slides. It will also be in the email that we send out later. And with that, Emily, if you could put the post-work group survey in the chat, uh, we'll be all set there. If you are filling out the survey for a P4P site, just a reminder to select one hospital that you're attending on behalf of for the attendance credit. Otherwise, everyone have a great rest of your day. And thank you, Sara, so much for presenting.
Anybody that's still on, I just want to call out the deadline for the presentations for the Fall Collaborative Wide Meeting is August 8th, so it's coming up very soon.